are able to join us on time. But also we'll welcome anybody else into the fold. So our plan today, we have a total of 2 hours. We don't have to completely take it all. I want to make the best use of everyone's time. I did get some feedback on the Kahoots, not a ton, so I'll disclose that. But some people, the feedback I got was positive in that it was kind of a good review to kind of focus on what you need to do a little bit more studying on. So over the past week, I've made some more Kahoots. We're going to focus on respiratory. We have a specific Kahoot on the VQ mismatch, kind of the big title of why is this patient hypoxic? So I made some specific Kahoot questions on that. We have some other kind of medical mop-up questions as well. So I am working just on one screen because I am remote today. I apologize. So I won't be able to fully see the chat. So I might ask Jen or the deputy or Kaylee to kind of keep an eye on the chat for me if but without further ado, let me work on getting that Kahoot open.
While you're doing that, I would love to say happy birthday to Baird. Today's his birthday. Happy birthday.
Happy birthday, Baird.
Happy birthday, Baird.
What are you going to do for your birthday, Baird? Oh my gosh, man, you need better plans. Okay, all right. I'm going to do it as a presentation. This is still relatively new to me. Can everyone see my screen okay? Is that working? Okay. I'm going to just put all of your lovely faces a little further down. Okay. So let me know if you can't see anything. Okay, I'm just going to move this. Oops. Okay. Hopefully that doesn't get in the way, or actually I'll put it all the way up there. Okay. So we're going to do a VQ mismatch for those of you who couldn't join us before. So we're going to go, you're going to either scan that QR code or put in that PIN number. Oh, look at this. Okay. Yes, and you're going to pick your names. Last time we did random picks of names. So let's see. I think we're going to do your favorite cartoon character or your favorite sandwich. Can be the choices as we kind of bring people in. We have one participant in as Rocky, Dagwood, a bear. That last one must be a cartoon character that I don't know. Okay. All right, let's get started. So VQ mismatch. So for those of you who remember this from the last time we did this, we had a quick hit just on basically why is this patient hypoxic, and a lot of that has to do with ventilation and perfusion mismatch. So on the Moodle, there's a quick hit that I did that may or may not be useful to you on VQ mismatch. So that's where these are pulled from. Which statement best defines ventilation? This is our warm-up question. All right, air reaching the alveoli. Okay, so Yeah, so a lot of people put diffusion. Um, and I think I understand kind of where you're going for that. I think this question was a little bit more basic in terms of the the process of ventilation versus the process of air and gas diffusion. Perfusion refers to, oops, sorry guys. All right, very good. Let's start to go a little faster as we kind of get our stretching done, right? We're kind of warming up a little bit. All right, optimal gas exchange occurs when, all right, very good. Which condition is most associated with low ventilation relative to perfusion? So remember, V is the ventilation and Q is the perfusion. We just did that. So when you think about test taking strategies, the fact that they put most in means that there might be other conditions that they list in the question options that are associated, but they want the one that is the most or the strongest. Okay. This one had a picture cue of that lady with the inhaler. I tried to get rid of it, but I couldn't find another good picture. All right. So asthma exacerbation. Do you guys want to talk to me about why asthma? Why that would be the right answer? It's worth having a quick discussion.
Well, asthma is basically hindering the ventilation or the oxygen coming into the lungs that allows for the gas exchange. So,
Yeah.
since to me it seems like pulmonary embolism, yes, it stops air exchange, but that's more so because the blood flow is not going through.
Yeah, it's more of a ventilation issue, right? So if you were like, I'm stuck on this question, I don't know why, right? A couple things we could knock off already, right? Are hypovolemic shock, because that's a perfusion problem, and pulmonary embolism, because that's a perfusion problem. So we could knock those off. So then we're left with asthma and high altitude. We don't deal with high altitude a lot here, so you could be like, oh, but it is in the textbook. And high altitude is really it's kind of multifactorial, right? But a lot of it has to do with kind of decreased partial pressure of oxygen. So you could say, well, maybe that fits a little bit, but the one that fits better, because the question, I believe, also said most would be asthma exacerbation. So I'm actually really glad that we got a chance to kind of dive down on this question a little bit more because I think it goes over the test taking strategies as well. Pulmonary embolism causes which type of VQ mismatch? All right. Very good, guys. In VQ mismatch, hypoxia occurs because Okay. So the answer is air and blood do not meet effectively. Um, some of what we call the foils here are a little bit complex. Air cannot bind, right? I can see why someone would say that, but I think the most appropriate answer is air and blood don't meet effectively. Um, you could also say that, well, the oxygen isn't binding, but that's more of a binding problem uh, with the hemoglobin rather than kind of the more general. Which EMS relevant condition commonly causes VQ mismatch due to poor ventilation? You guys are good. Everyone got that one. Perfect. CHF with pulmonary edema because it really has the question is poor ventilation. Sepsis has to do with perfusion. Stroke is what we call a foil that is really kind of wouldn't even apply. People could get a little jammed up on PE, but PE is much more of a perfusion problem than a ventilation problem. All right, which finding would you expect a significant VQ mismatch? Nice, nicely done. Okay. Real, and that really is kind of the definition of kind of why is this patient hypoxic? It's really kind of why is this patient hypoxic despite the oxygen um, treatment. So the triangle one, normal oxygenation, that doesn't fit. The hypercapnia only doesn't fit as well. So now we're left really with two options. We have metabolic acidosis, right? Um, and then we have hypoxemia, right? Um, so the best answer for this would be hypoxemia despite oxygen. All right, this is just a practice throw-in question. Why is understanding VQ mismatch important for EMS providers? All right, very good. I think this is our final one. Which statement best defines ventilation? All right, this question should look familiar. Okay, so pulmonary capillary blood flow. Oh, I can see how people would say kind of oxygen delivery, but the question is more kind of on the perfusion side. Um, but that's a relatively challenging one. Optimal gas exchange occurs when all right, great. That should look familiar as well. We're starting to repeat questions just to get the practice in. All right, which condition is most associated with low ventilation relative to perfusion? All right, fabulous. Okay. All right, I'm going to stop sharing. That was our warm up. What we just did with some of the repeat questions was what you call space repetition. So just kind of repeating a question or repeating a section of learning kind of in spacing. All right. So do we have anybody else who has joined us? No, we're still at all of our folks. Okay. I'm going to have you take a 3-minute stretch while I just load up the next. Okay, that was our warm up. We're going to do a whole larger bank of test questions now, just to kind of really get you um, uh, in the stride of doing a lot of questions at once, which is kind of what we have on the exam. All right. Okay. So that's our pin. So this is going to be a lot of physiology, fluid balance, some cell stuff
I don't
with a
see,
little.
we don't see the,
Oh, sorry. My bad. I didn't share. All right, I should be sharing now. Can I get an audible if you see it?
Yes, we have it.
Thanks. Okay, is everybody lined up who wants to get lined up in the Kahoot? We're going to get started. Pathophysiology is best defined as the study of, sorry. All right, fabulous. That was a good warm-up one. An increase in cell size without an increase in cell number is known as. Now, remember we talked about this as what we call a stem, so basically the basic part of the question. You might already know the answer without looking at the answers. So sometimes if you're doing this on a paper test or a computer test, you can kind of put your hand up over the answers just to make sure that what you're thinking of as the answer is coming from memory rather than like an error in how you read the question options. Nicely done. Okay, so the answer is hypertrophy. Um, Metaphase is a different DNA phase, but basically this is kind of going after um, kind of your knowledge of what would be hyper or what would be dys. Dysplasia would be the wrong answer because that means an abnormality. So it would be the two good options that you'd have to kind of mentally figure out is hyperplasia versus hypertrophy, and hypertrophy is the right answer. Adaptation involves replacement of one cell with another, with one cell type with another. All right, very good. Edema is defined as. All right, good. Okay. So the answer is excessive interstitial fluid. Okay. Um, excessive intravascular volume, I can see why uh, people would pick that, but the true definition of edema is something interstitial rather than intravascular. An example of increased intravascular edema, fluid rather, would be, let's say we give someone 4 liters of fluid for as an overcorrection for their sepsis. Let's say they had a GI event and are a little septic, and then we quickly load them with a lot of fluid. That would be excessive intravascular volume, but you don't get edema until you get that fluid more in other spaces.
Dr. Dyer, can I make a comment?
Yes.
So I've always remembered that is because, like, I think of intramurals. We always say the word wrong. It's not intramurals, it's intramurals because it's
Oh,
within the school. So intra is always within whatever the next word is, and inter
oh,
is always between. So intra is within the. So anyway, we always mess that up because I always remember that because of that word intramurals. It's really
oh, that
intramurals is really what the word is.
Yeah, that's a really great memory key,
Yep.
right? That's kind of what we call it, like a memory key. That's a good way of remembering it. Yeah, throw that in the chat so people can hold on to that idea. Okay, a common cause of edema due to decreased oncotic pressure is. Okay, I'm gonna actually move this because it's covering. It's no good place for this. Common cause of edema due to a decreased oncotic pressure. Okay. So the correct answer is low serum proteins. Okay. Let's go over the other answers that kind of you guys picked. Um, support the lymphatic obstruction. Why are you thinking that's a good answer? What are just the thought processes behind that one? It makes a lot of sense, right? So the reason that the low serum protein is more, the question is really going after oncotic pressure, right? So that means kind of that kind of intravascular pressure. That's kind of what the question is really going after. The answers, the best answer for that is the low serum protein. Lymphatic obstruction kind of makes sense because that's what you have kind of lymph obstructed, but really they were kind of going after the key to this question is really reading the oncotic pressure. So I'll admit that that's a tough one, and we'll move on. Isotonic fluid deficit is best described as. Okay. proportional loss of sodium and water. So the key to this question is they're really going after isotonic fluid. So isotonic fluid meaning kind of the balanced fluid. So it makes sense if isotonic means kind of a balanced fluid. We could quibble about whether or not that's physiologically true in terms of what's best for replacement for patients. But because of that, the best answer is the answer of proportional loss of sodium and water. Which electrolyte has a normal serum range of 3.5 to 5? Okay, answer is potassium. Okay. The most frequent answer that other people did was sodium. So the normal sodium range, depending on the lab, but is around let's say 134 to 146. That would be kind of your average range. So those numbers are really high, right? So if I was taking this test and I was like, I'm not exactly sure, but I could say I know it's not sodium because those are usually in the triple digits. So we have 3 digits for that. Calcium, I would quibble with the people that wrote the test and say what type of calcium, but we know those tend to be at kind of lower numbers, and then magnesium, kind of a normal for a magnesium is kind of low normal is 2, so that wouldn't fit. There we go. Okay. Hypokalemia is most likely to cause, again, getting into some pathophys questions. Fabulous. All right. Good question. A decrease in blood pH indicates okay, a decrease in blood pH indicates acidosis. Okay. Um, so looking at the other options, it wouldn't be alkalosis because that would be an increase in blood pH. So we can kind of eliminate that one. Um, Buffer failure, I guess you could say that that would be another potential, but the best answer is really the definition of decreased blood pH, which would be acidosis. And if you had a normal blood pH, that would be an example of something that was compensated. But if this is just a frank decrease in the blood pH, it's not compensated. Respiratory acidosis is most commonly caused by okay, hypoventilation. Okay. Um, Hyperventilation would cause respiratory alkalosis. So I think if you answered that, you were going with the ventilation part of it, right? But kind of in the opposite direction. So if I was taking this test question, I would look at all the answers, and one has to, so basically 2 have to do with ventilation, and 2 have to do with something metabolic, right? So vomiting is not a respiratory problem, it's a metabolic problem because you end up kind of vomiting out all your acid because you're vomiting out all your stomach acid or stomach buffer, right? And then excess bicarb is also a metabolic answer, right? So the question is asking specifically for respiratory, right? So we know if it's specifically asking for respiratory, the only two options that could be right would be ventilation. All right, I apologize for meetings going on without me there, but you guys are important and I am doing this with you guys and I'll catch up with the meeting later. All right. The primary compensatory mechanism for respiratory acidosis is, so we're going to take a pause. We're going to think about what the answer is, and then we're going to see if it shows up in the answers. Fabulous. Okay. All right. I'm actually glad because this is a pH question that's worth diving down into. Okay. So, primary compensatory mechanism for respiratory acidosis. So, if we think about the question, this is a hard one actually, so this is kind of logicking this one out. Um, you could say yes, increase ventilation, but they want to, I think, specifically go for um, the other parts of the pH balance and the compensation. So renal bicarb retention would be more the correct answer. So if you think about someone who has bad COPD, if they chronically have a decreased pH and elevated PCO2, when you look at their blood gases, they actually seem to not seem to do, hold on to bicarb as kind of that buffer. Um, Increased ventilatory rate. Again, this is a hard question. I don't think we'd put a question this challenging on that. I think you could read that as a potential compensation mechanism, but I think the better answer is the renal bicarbonate retention. Um, Increased potassium excretion really is more of a metabolic thing. And then metabolic alkalosis is, you could say that that's another potential answer because that's kind of the process of buffering. So I would actually say this is probably like a not a great question. Metabolic acidosis may result from, okay, lactic acidosis. Good job. Excessive vomiting. I think that other picture was getting at excessive vomiting. Excessive vomiting most commonly causes. So think about what you think the answer is. Very good. Okay. So you guys are logicking this out correctly. So this is vomiting. So this is probably not a respiratory component at all, some type of metabolic component, right? So of the metabolic answers, we have metabolic alkalosis or metabolic acidosis. Um, you could make the argument that you'd get metabolic acidosis if you had prolonged vomiting and your volume was down, but the best answer for the simple question just of excessive vomiting would be metabolic alkalosis. All right. Reversible cell injury ultimately results in All right, very good. Most dangerous early byproduct from hypoxic injury. Right. So this is a question that I think is a little bit more complex than we would get on the exam, honestly. Um, but is kind of fair game. I think it's a hard one because if I was looking at this question, I'd be looking at eliminating carbon dioxide because it's not really an early byproduct of hypoxia. Um, I would struggle between saying, is it free radicals or is it lactate? But free radicals actually fits more in terms of the byproduct that directly causes damage.
What is a free radical?
What is a free radical? Okay, so a free radical is not someone who is rolling around in the 60s. A free radical is basically a um, a component that uh, that basically damages cells. They're very small. So I'm trying to give a good example of a free radical. Um, you could kind of think about it as almost like radiation, right? Causing kind of increased damage to DNA. Um, and it's kind of these small components that actually can kind of get into cells and are charged frequently and then cause damage that way.
Would the increase in hydrogen ions be considered free radicals?
Um, I think you could, I don't know if you'd really call that a increased free radicals. Um, an example of kind of a charged, similar kind of charged particle would be something like ozone, causing damage. But yeah, I don't think this would be a question we'd be asking you.
Thank you.
All right. Yeah, he's like, please. Yeah. Carbon dioxide causes cellular injury primarily by, all right, good. See, I think this is a little bit more straightforward of a question. Virus is different from bacteria because viruses, okay. So really the definition of a virus is that it replicates only in the host cell. If I was looking at this question and I was stymied and I was like, I don't really know the answer to this one, um, I would do it by kind of elimination, right? So the one answer, if we're going to look at this, what's the one answer that everyone would kind of say we know is wrong based on treatment?
Affected by
Antibiotics.
Antibiotics, right? Remember, you go to the doctor says you have the flu, and they say, I'm sorry, you have the flu's a virus, and someone says, oh, can I take any antibiotics? And they explain to you, well, the flu is a virus, antibiotics don't help. So we could initially eliminate that, right? And then the next answers kind of really go a little bit on what we call type 1 recall. So just basically what you recall about viruses. So we also know that viruses don't contain cytoplasm, they just have RNA. So, and that we know that viruses really don't reproduce independently. They replicate only inside the host cell. So this is a question where you could logic away one answer, are affected by antibiotics, but the other ones you'd have to just kind of have some baseline recall. Most common reaction to infection. Okay, inflammation, right? Um, Antibody production. That could be an answer. I would say that's a poorly worded foil. I'm glad you didn't pick shock because this question is really trying to get at the most common reaction to infection. Most people who have an infection don't have shock. And for those of you who picked fever only, right? I would eliminate that when I was looking at the question because it has the word only in it, right? So it means it's completely exclusionary. So that would be the kind of the teaching point that I think is behind that is just the fever only is excludes other potential options. Okay, now we're into double points. Local inflammatory responses include, all right, guys did really well on that one. So this question is going after what you know about necrosis. All right, really good. Hypoperfusion is best defined as, fabulous, you guys know it. Early compensatory responses to hypoperfusion include, so we know with this question, they're really going to be asking for some listing of responses. And the specific thing about this question is it says early. Okay, answer is release of catecholamines. Okay. Um, let's go look at the other answer that you guys did commonly. So reduced respiratory rate as a response to an early compensation for hypoperfusion. If you think to your clinical lives, right? You go to a household and there is a 50-year-old male who has had a significant GI bleed. Family calls, so there's blood all over the bathroom. We're worried about him. What do you think when you go see that guy, what do you think his respiratory rate is?
Elevated.
Yeah, yeah, because he's really trying to get in more oxygen, right? He's feeling like he's not fully perfused. So if we think about the classifications of shock, um, elevated respiratory rate would be one of them, right? When people kind of breathe kind of fast. Therefore, reduced respiratory rate would be kind of the opposite of that. Now, I actually think the other potential trap to this question, which you guys did not fall in, is the triangle response of bradycardia and vasodilatation. Why is that not the answer?
I, that would be a late response.
Yeah, so it'd be late. So the question's really going after early. Fabulous. Okay. Persistent hypoperfusion eventually leads to. Okay. All right. Worsening tissue perfusion. All right. Let's look at answer circle, right? Which is resolution of shock. Okay. Um, that kind of would make sense because the question really didn't ask for um they're asking more for a physiologic thing rather than a kind of an end game, right? I would look at resolution of shock, and that really kind of doesn't fit. So I think this question is a really great example of even if it's a simple question, fully reading the question. Because I think if you took a step back and fully read the question again, even though it's a short question, um, you might not have kind of fallen into that trap. Okay. And then the other answers increase urine output, right? We typically have decreased urine output when we don't perfuse our kidneys and improve myocardial function. Well, that's really not kind of what eventually persistent hypoperfusion decreases your coronary perfusion pressure, so you're not going to be perfusing your heart well. Okay. So gets into definitions of types of shock. So you're going to have to know those types of shock. What types of shock result from pump failure? All right, very good. Septic shock. So again, another definition of shock, definition of types of shock, classified as fabulous, distributive. A key clinical indicator of worsening shock is, all right. I think this shows that you guys actually know your shock well. So if you're going to be focusing on what to study, I would just say a cursory review of shock, but don't spend a lot of time on it because I think you guys, this is proving that I think you know it. All right. Multiple organ dysfunction syndrome is characterized by, All right, very good. First line of defense against a pathogen includes very good. The key to this question is they're asking for the first line. Acquired immunity differs from natural immunity because it is. Okay, it is highly specific. So an example of that would be the flu shot. The flu shot gives you acquired immunity to something very specific. The flu shot, for those of you who recall a little bit about flu shots, typically covers 3 to 4 types of species of flu. Primary cells involved in humoral immunity are okay. Answer. This is probably a little bit more detail than we would do for the exam, right? So the answer is B, lymphocytes. Opsonation refers to antibodies. All right. You had some good answers there. All right, this is a harder question and we wouldn't go into this much detail. Um, All right, we're going to try this one, but again, probably a lot more detail than we do. Cell-mediated immunity, defense against. Okay, yeah, if you didn't know this one, I think this is fine. Don't stress about that. This is kind of a lot of detail that we probably wouldn't, but the correct answer is viruses. Okay, type 1 hypersensitivity. Okay, this is a part of immunology that actually does have to do with kind of what we do every day, um, particularly when you think about different types of reactions. Okay, the answer is immediate mediator release. Okay, I'm actually going to skip this question because I don't think it's as important. Immunodeficiency can be caused by. Okay, so the answer is stress and trauma. All right. So the other foil that I think could be confusing is they have something about aging, right? But the answer they have about aging is normal aging only, right? So you guys appropriately did not pick that. Um, uh, because it had kind of that only in it, right? Just like that other question we had about fever, it had fever only in it. And we know that stress and trauma can cause a kind of a decreased level of response of the immune system. All right, let me see this one. All right, I'm going to skip this one. Okay, I'm not going to skip this one because it has to do with a disease process that's important to us. So mast cell degranulation releases substances that cause. All right. I think you guys got that. That's good. I'm going to skip this one because I don't think it's important for us. I am going to include this one because I think bradykinin is important to us because it shows up in types of reactions. So bradykinin contributes to inflammation by causing. Okay, increased vascular permeability. This is a little bit of a harder one, but if you go back to think about inflammatory mediators, bradykinin is worth 5 minutes of your time to go back and kind of review the textbook. The way I would remember this is bradykinin has a lot to do with a specific type of edema that I'm sure you have all seen before, and that is ACE-related angioedema. So if you've ever seen anybody with ACE-related angioedema, they do not have the other systemic allergic symptoms that you typically see in someone who comes in with a peanut allergy. They tend not to have GI symptoms. They tend not to have a rash or hives. But what they do have, what do they have when they have ACE-related angioedema? You walk in the room and it's someone who's been on captopril for years, and they say, I just woke up this way, and
They have the swelling of the lips and facial area.
yeah,
Dystonic
exactly.
reaction.
Not dystonic, no, but they have that swelling kind of that facial area, right?
Yep.
And that swelling is directly related to increased vascular permeability. So all of a sudden their vasculature becomes really permeable, and all these fluids start to collect in places that normally don't collect fluid, like in their face. And so that's kind of the cause of it. Um, Other people put platelet aggregation. I think this question is really going specifically for kind of the bradykinin and that type of permeability. But don't feel bad if you got that one wrong. That's kind of a lot of complexity. Wound healing by primary intention involves. Okay, so the answer is minimal tissue loss. When they say wound healing by primary intention, it just means the wound is going to heal kind of on its own, um, frequently with a bandage or something like that. Chronic inflammation, um, which some people picked, wouldn't be an answer. Delayed closure isn't suggested by the question because it's primary intention, kind of primary wound closure. Um, and extensive tissue loss would be not an answer because they're really specifically looking for kind of the primary way. Let's say you cut yourself or get a burn that you're going to be healing. And in general, that the first step of that is not extensive tissue loss. I am going to skip this one. All right. I'm going to stop sharing now because we've been going for an hour and 10 minutes. I'm going to have you guys take a stretch break, and I'm going to do a pivot to some different types of questions. All right, so I'm going to do a 5-minute stretch break. Yeah, yeah, right. All right, we're going to resettle. We did a lot of hard work on some really hard topics. We're going to pivot into a shorter session, and we're going to do this one on toxicology and toxidromes.
Dr. Dyer, before you go or move on, I had a question about the blood, like kind of levels for different things. I've learned numbers for the ones that kind of like we measure, like pulse ox and stuff
Hmm.
like that. And then, but for the ones like calcium, potassium, it's more like I just understand if the potassium's high, it shows up in a peak T wave and it can affect the
Hmm.
contractility of the heart rate. Which value? Because I those other things we never see those values pre-hospitally. But as Boston EMS paramedics, which values would you like us to be able to memorize?
Yeah, so I think I hear what you're saying, Baird, in terms of kind of what we see. We also kind of pull questions from kind of the national, the major national textbooks, right? Because we want to use questions that have been vetted before, and that's what they come from. And if you look at most of the standard textbooks, they actually do talk a little bit more in detail about electrolytes than we traditionally cover, right? Because that's encompassing all of ALS provisions, which depending on where you work, actually really could include an understanding of impacts of electrolytes on patients, particularly if you're doing more interfacility transport work, doing more these days, more and more home medical care, right? You know, where medics are going into the home, taking care of the heart failure patient, understanding potassium, sodium, and things like that. But Sue had her hand raised, and then I'll answer some more specifics.
To dovetail onto what Dr. Dyer was saying, it is true that we don't usually see those numbers, but more and more we're going to skilled nursing facilities, allied health, agencies, and they're handing us charts.
Yeah.
And you know, I can't tell you how many times we go to abnormal EKG. Well, we know to look at the cardiogram and see what do you mean by abnormal. If we have a sense of the really critical electrolyte numbers, then you can take a quick look at them and say, is it low or is it very low? You know, that kind of a thing. So personally, I don't think it's a bad thing to know your normal values for potassium, calcium, and sodium.
Yeah.
I don't think that's bad because those will affect the cardiogram and kind of how we react to it.
Yeah.
And we don't usually see it. You're right, Baird, but we could see it. So, we
Yeah.
can stretch ourselves a little bit.
Yeah. And we are seeing a lot more of this as if you go to some large hospital systems, we don't see it quite as much in our area, but it's coming, right? The future
We also do a lot of
is
event
here.
medicine, and they
Yeah.
have the eye stats at the marathon. Do you have the eye stats at the half marathons or no? No, okay.
What we do at the half, it's unusual for someone to get a low sodium at a half, but we
Mm.
do typically carry at least maybe one at the half. So I think sodium, potassium, magnesium, and calcium, all of those can impact an EKG, right? You should also know the ranges for a normal pH, a normal PCO2, therefore an abnormal one and abnormally high PCO2, abnormally high PCO2, and you should also know the averages for bicarb as well, because those are all in our wheelhouse, right? We might get called to someone who's sitting at home, right? Getting their home visit for their heart failures on a LASIK strip, right? And someone might call and say, hey, we just got their labs back. Their K is 2.4. You would need to know that that's not normal and what to look for on the EKG for that not normal lab. All right, but that's Baird. I really appreciate that question. I think that helps everyone else out too. All right, I'm going to get started with another one. We're going to do this one. Let me work on sharing. Should have a share there. This is a quick one on toxidromes. There's also a quick hit available on the Moodle on toxidromes. Okay, we're going to get started. Patient with flushed skin, dry mucous membranes, dilated pupils, hyperthermia, and delirium. Which toxidrome is most consistent? So think about your toxidromes, think about what the answer is, and let's see if we're going to see it here. All right. Cholinergic. Right. Let's break this down a little bit. Okay. So they have dilated pupils, flushed, dry mucous membranes, dilated pupils, hyperthermia, and delirium. If you can't remember which toxidrome this is, let's anchor on what we do know, right? So if we think about the cholinergic toxidrome, which is the answer that you guys most frequently picked, and we think about all those drugs in the drug box, right? In that black box or gray black box, they're atropine and 2-PAM, right? And we think about the syndrome that would make us think about, oh, I think we have a nerve agent, right? The mnemonics for that one are, we have a couple, right? Sludge or sludge M and dumbbells. If we take the sludge, right, that's salivation, lacrimation, urination, meiosis, right? So small pupils, GI cramping, diarrhea, emesis, um, you kind of get the drift, right? So all of those chemicals that can be nerve agents, which could be a pesticide, it could be, a chemical weapon, right? All of those give you cholinergic symptoms, right? And the mnemonic for the cholinergic symptoms is that dumbbells or that sludge, right? All of those are actually opposite the symptoms that are shown in this patient, right? Which is dry mucous membranes, dilated pupils, hyperthermia, and delirium, right? They don't mention urination and stuff like that, right? So, um, the answer to this one is anticholinergic, right? And can you guys give me examples of some drugs that are anticholinergic? You could throw it in the chat if you're feeling not sure. So if someone went to CVS and they took an entire bottle of Benadryl, they would present this way, right? Is there a mnemonic that helps us remember um, kind of the anticholinergic toxidrome? Yeah, the Mad as a Hatter one, right? Okay. So the so it's mad as a hatter, blind as a bat, right? So dilated pupils, right? Anybody know the rest of that one, that mnemonic? You want to shout it out?
The hot as a hair, or
Yep.
yep, hot as a hair.
And dry as a,
Bone. No.
right.
Yes. Okay.
Yes. Yes. Okay, perfect. All right. So why was this question hard? Let's go through it. I think the reason this question was hard is there's a bunch of symptoms, right? And you had to go through some logic, right? So you had to figure out each one of these symptoms without a drug, right? Because if I had given you the question and said someone went to CVS and took an entire bottle of Benadryl, you could probably figure that out, probably because you've seen it before, right? Um, but to keep the question short, they just gave you signs and symptoms. So you had to put the signs and symptoms into a bucket, right? All these signs and symptoms, what do they suggest? And then what of these signs and symptoms fit into which toxidrome? And then you had to pick the name of the toxidrome, right? So that's why this question requires kind of three steps of kind of logic there, right? I think the good thing, right, is that you all knew it wasn't an opiate. You all knew that it wasn't sedative hypnotic, but I think where you got jammed up is a cholinergic versus anticholinergic. Okay, that stuff is fair game for the test. So go back, look at some infographics. You could go back and look at the Moodle, but spend a little bit of time kind of knowing what's the mnemonics that track for cholinergic and for anticholinergic, or whatever way you kind of remember that. All right. Guess what? Our next question helps us with that. So, which mnemonic is commonly used to describe the cholinergic toxidrome, right? So that would be things like pesticides, that would be things like nerve agent. All right, good. So you guys knew it. We just reviewed it. Excellent. Which finding best differentiates anticholinergic from sympathomimetic? So this question requires that you know not everything about anticholinergic, but some signs and symptoms, and not everything about sympathomimetic, but some, right? So let's look at our potential answers. Okay, this is a hard question. Okay. But it's completely within your wheelhouse. Okay. So what they're going after in this question is two things that seem very similar: anticholinergic toxicity and sympathomimetic, right? Let's give a clinical, we've already kind of done a couple of clinical examples of anticholinergic. So the classic one would be the Benadryl overdose or the TCA overdose, right? That patient would be expected to be agitated, have mydriasis, be tachycardic, expected to be all those things. But that person, if they're anticholinergic, would not have diaphoresis, right? And now, if we think back to the last cocaine overdose you saw, or the last meth overdose, right? Assuming they weren't lying in a snowbank, right? That person could have mydriasis, could have agitation, is most definitely tachycardic. But the difference between that person and the anticholinergic one is they're really, really wet, right? So they're very diaphoretic, right? So this is a hard question because it takes several steps of logic. But because the question is asking the best differentiation. So how do I tell the difference between anticholinergic and sympathomimetic? All right, hard question. A patient presents with bronchospasm, copious secretions, vomiting, and pinpoint pupils. Which toxidrome is most likely? You guys know this. I know you know it.
I think the picture's a big hint.
Unfortunately, there'll be no pictures on your exam. Okay, cholinergic, right? The mnemonic that we're going after is that sludge or dumbbells. Okay. Um, I see why someone might have said opiate, right? Because you're focusing on the pinpoint pupils. But in general, opiate overdoses don't have bronchospasm in general. I know sometimes we see it, don't have copious secretions, and the overdose doesn't necessarily have vomiting as kind of the what this question is looking at as the most likely. All right. No one picked sedative hypnotic. Okay. One person picked um, anticholinergic. The things that would go against anticholinergic is the copious secretions and the pinpoint pupils, right? So if I was
It was me.
antichol,
I'm still struggling to figure out a trick to remember anticholinergic versus cholinergic. Those two words.
okay,
I'm just mixing them up.
mixing them up exactly. All right. So let me, you know what, Brad, what I'm going to do is I'm going to have you go back to the the Toxidrome quick hit because that shows you in picture form the difference between cholinergic and anticholinergic.
I
But
understand the
if
difference. It's just every time you ask it, I'm going, okay, now which one is it, anti or non-anti? Like
non-anti,
I'm just
yeah.
like I'm mix, I'm just mixing them up.
Yeah. Yeah, so I think the way so I think the mental way around that, it could be a rote memorization thing, which I tend not to go to, but sometimes it is. But it's remembering that anticholinergic is mad as a hatter, blind as a bat, hot as a hare, dry as a bone, right? Those are the typical kind of anticholinergic toxidrome things that we remember it.
The
If
problem,
you need,
I'm trying to like anticholinergic. I'm like, okay, A as in anagram, but that's not the one. That's or cholinergic is chemicals. Like I'm trying to come up with a trick to remind myself which one goes with which. I get the
okay,
lists. I'm just like,
yeah, which one goes with it? Okay, let me give you a visual. All right, because if you focus on learning one, uh, you'll uh, you kind of by default will know the ones that it's not. So when I'm teaching the residents about cholinergic, because they see a lot of anticholinergic stuff in the ED, they're actually kind of good at that, right? They struggle mightily with anything hazmat, and that kind of fits into the cholinergic dump of things where they're like, oh yeah, because they just don't see it a lot, right? Not that we see a lot either. But the visual that I sometimes use to help people remember that is do you know SpongeBob? Right? SpongeBob SquarePants. Right? Everyone's going where she's going with this, right? So the visual that I sometimes use is SpongeBob SquarePants to describe cholinergic, right? If you took SpongeBob SquarePants and you squeezed him in the middle, right? What would come out? He's a sponge, right? So
water.
right. There's going to be just a lot of water coming out. And if you remember the picture of SpongeBob SquarePants, his eyes are kind of buggy anyway, right? So if you squeezed him really hard, his eyes would kind of also um, uh, bug out as well. So I use that to kind of as a visual to help people remember kind of what cholinergic looks like. Does that help at all? If it's helpful, take it. If it's not, um, you can push it to the curb. Anybody else have any other ways of remembering that?
Personally, I misread the question initially, but personally, my thing was just focus on what cholinergic was, and then anything opposite of that.
Anything opposite of cholinergic,
Yeah,
right?
so I focused on one and just learned that, and then anything opposite that would be the anti-cholinergic one.
Okay. All right. We'll all get there, right? Which substance is most commonly associated with sympathomimetic? All right, fabulous. So you guys know sympathomimetic. All right. Which combination of finding is most consistent with opioid? All right. Easy peasy for us. Which finding is least likely to be present in sedative hypnotic? So, what are some, before we dive into the answers, what are some examples of a sedative hypnotic? Just from your own clinical practice.
Would mushrooms be a sedative hypnotic?
Um, Not really, no. I mean, there are mushrooms. There's many different categories of mushrooms. Some of them could be, but let's say if we stay strictly in the land of pharmaceuticals.
Benzodiazepine.
Fabulous. A benzo, right? So we think about benzos, we think about things like barbiturates, although not commonly prescribed, but increasingly prescribed actually for alcohol withdrawal. They actually work quite nicely. Um, uh, Other examples of sedative hypnotics might be things that we also give IV, right? Propofol if someone had a procedure, etomidate if we, are thinking about kind of anesthetic agents. So this question is now asking you to know what are sedative hypnotics? What are the common toxicity? And it's kind of an opposite question, which finding is least likely? So let's take a look at the question. All right, you guys got it. If we look at the other things, right, they are very likely to be seen with a sedative hypnotic. If you see someone with a benzo overdose, they have slurred speech, they have CNS depression. They may or may not have hypotension, but they're definitely not diaphoretic like that sympathomimetic patient. Okay, so remember we talked before when we talked about taking taking tests. Um, and you think about a clinical vignette, sometimes looking at the last part of the stem, which medication class is most likely responsible. So if I was looking at this question, I'm looking at it briefly and I'm like, okay, I'm going to focus on what the question is. So which medication class is most likely responsible? And then we gave you symptoms of hallucinations, warm, dry skin, tachycardia, and urinary retention. So though that is kind of our toxidrome. Okay, so the answer is tricyclics. Again, this is kind of a three-step question. It's asking you for a medication class, but it's also asking you to recognize the toxidrome. And the toxidrome up here is that's mentioned is the anticholinergic toxidrome. And when we think about drugs that fit in the anticholinergic toxidrome, it would be things like the sedating antihistamines, tricyclic antidepressants, and some of the kind of standard antipsychotics like Trilofan, like Thorazine, all those things kind of fall into that class. Nobody picked opioids, right? Because that's kind of absolutely not what that patient would be necessarily looking like. Okay. Which toxidrome is caused by inhibition of acetylcholinesterase. Okay, so this question is asking you to identify a toxidrome. So we have a couple of possibilities, but it's also asking you to have a memory recall of why, um, well, basically what enzyme is involved, right? But the enzyme involved is acetylcholinesterase. So we can already rule out which toxidrome. We have opiate, sedative, hypnotic, anticholinergic, or cholinergic. Which do you think we could rule out of those? Pick two that we could rule out.
Opioid.
Yeah, perfect. Okay, so we know even before we look at the answers that we can kind of eliminate that, right? And then I would also say we could eliminate sedative hypnotic, right? So now we're actually down to just three: sympathomimetic, anticholinergic, and cholinergic. So let's look at some of our options. Okay, the answer is cholinergic. Don't freak out if you don't remember this one, right? Because this is a little bit of a harder question because it's asking you to kind of think through a couple of steps, right? A quick way to remember this one is if you remember back to when we were teaching about WMD agents, right? We talk about the 2-PAM kit. We talk about the Duodope kit. It has a combination of atropine and 2-PAM pyrrolidoxine chloride, right? And there's a visual that sometimes people use to teach what the 2-PAM chloride does. And that visual is a Pac-Man with a triangle stuffed in its mouth, right? And the additional part of that visual is a crowbar basically freeing the triangle from the Pac-Man's mouth, right? And what that visual is trying to describe is the Pac-Man is the enzyme cholinesterase, right? The nerve agent is inhibiting that enzyme cholinesterase, right? And the med we have in the drug box to take care of that is the 2-PAM. Right. So more simply stated, they're just looking for the toxidrome. We've already figured out that it's not going to be opiate. We already eliminated some uh, sedative hypnotic, right? And so then we're really down to that pesky cholinergic versus anticholinergic, right? So in this question, you really would kind of need to know that uh, drugs are chemicals that cause the cholinergic toxidrome do that partially by inhibition of that enzyme. That's a tough one. All right. Which EKG finding is most concerning, not most common, most concerning in a patient with a suspected TCA overdose? Okay, the EKG finding most concerning, right, would be a widened QRS. The EKG finding most common would be tachycardia, right, in someone who had a TCA overdose. But this question just asks you to spend 5 minutes looking back at the textbook and saying, what do I know about TCA overdoses and their impact on the EKG? And the most concerning finding is someone with a widened QRS because they can go on to cardiovascular collapse. Sinus bradycardia would be unusual, right? ST depression is really kind of going more for ischemic stuff. And prolonged PR interval, again, that might happen, but what we're really looking for is the most concerning finding. Cardiac toxicity in tricyclic antidepressant overdose is primarily due to, okay, answer is sodium channel blockade. Okay, this is what we kind of call a type 1 question. It's just information that you should just go back and review cardiac toxicities of drugs. So I'd recommend that you review tricyclic antidepressants, review all of the sodium channel blockers, and then review a little bit about beta blocker overdose and calcium channel blocker overdose as well. Which medication is first line for seizure management for tricyclic antidepressant toxicity? Okay, benzodiazepines. Okay. The tricky foil in this is bicarb, right? Um, Bicarb is indicated, right? But the question is really asking for seizure management. Bicarb would be the first drug indicated if we had wide QRS, but they're really going for the benzos. All right. Sodium bicarbonate is administered to TCA toxicity primarily to, all right, fabulous. Which toxidrome is most likely to present with diaphoresis, agitation, tachycardia, and hypertension? Okay, sympathomimetic. So they're looking for the Adderall overdose, the cocaine overdose, the meth overdose. Okay. And why, if we were just thinking about the anticholinergic toxidrome, right? Which can present with agitation, tachycardia, and hypertension, but typically not with diaphoresis. Okay. Patient is hypertensive, diaphoretic. Their temp is 100. They're very agitated. Their pupils are dilated. Which toxidrome fits? Okay, sympathomimetic. Okay, a firefighter removes this patient who's altered, hypotensive, hypoxic, despite oxygen and IV fluids. Which toxin is most suspect? So sorry, I don't have a great, I think the next picture helps us with what they remove them from. All right, cyanide. You guys got it. All right, folks, I think this is going to be, yep, this is going to be our last question because I have to move on. So, a patient with nausea, vomiting, excess salivation, bronchospasm, and muscle twitching after a work exposure. So, we're giving you a little clue that this happened at work. All right. Cholinergic. I think you guys got it. This hard cholinergic for anticholinergic. The visual to remember is, if helpful, is that SpongeBob SquarePants. All right, one more and we're done. The EKG shows a QRS duration of 160 and ventricular ectopy. Which treatment is most appropriate? Okay. So this question I think could be better worded. We're limited in cahoots about how long the question can be. The best answer would be sodium bicarb. If you answered mag sulfate, I can see kind of your logic because it was otherwise kind of not specific uh, as well. And really bad magnesium deficiencies actually can cause some QRS widening and some ectopy as well. All right. Got to check the podium. All right. All right, guys. Thanks for hanging in there. You guys did a great job. I'm gonna stop sharing. Um, Feedback is appreciated if it's helpful if this is helpful or not. I think we did hit a couple of good topics where I think collectively we all have a fault line, right? So I think reviewing some toxidrome stuff I think would be valuable. Baird had that really good question about kind of electrolyte stuff as well. I think you guys are pretty good on the basic kind of pathophys types of questions. I think you guys know shock well, right? So if you're going to review anything, I would only spend 5 or 10 minutes on shock because you all seem to kind of perform relatively well on those shock questions. So, all right. Well, thanks for spending your morning with us.
And if anybody wants, I have obviously both the Sanders paramedic textbook and the Nancy Caroline's Emergency Care in the Streets. I can give you a copy of the chapters on
mm,
toxidromes and the acid base and whatever you think you want to look into and study more. If you don't have it, I mean, I know Bear took his program a long time ago, so it might have to dust it off. I know
yeah,
you and I together, but
yeah,
anyway, reach out to me if you're looking for that kind of review and you don't already have it. Also,
yeah,
just remember there's a ton of stuff already on the Moodle. Life in the Fast Lane, invaluable. Osmosis.org, invaluable. All of this kind of stuff is open source meds, all vetted, really good stuff. Okay,
yeah.
guys?
Yeah, so I think actually the deputy brings up a good point that I think a lot of our stuff in the Moodle is not meant to be foundational, it's meant to be review. Um, and that can be a little disconcerting actually when all of a sudden you're like, wait a minute, I'm still kind of searching in my brain for where this stuff is filed. So I actually think the deputy's offer of a textbook chapter as foundational review for things like pH acid base, for things like toxidromes, for things like basic effects of electrolytes and EKGs. I actually think that would be good kind of foundational work. Not that you're going to, spend 16 hours, you're all busy restudying everything in that textbook, but kind of looking over kind of pertinent stuff for you. So I think that's a valuable exercise. So
Okay, so I know Dr. Dyer has a 10 o'clock, so I'm going to let everybody go. Thank you very much. I appreciate you coming. Claudina, I hope this was helpful, even though I know you're in the background, but spread the word. Our next Teaching Tuesday will be next Tuesday, 5 p.m., and the link will go out on Tuesday. Okay? Bye, guys.